Although that's very exciting. Always nice to have a dance in the middle of a session, isn't it? I hope everyone get the opportunity to get up and do some lunges and jump around, get your heart flowing. Dan, if you're back on.
Yeah, I'm here. Shall I just wait a few moments for...
Yeah, wait a few minutes. I thought you were going to be presenting a video and maybe a dance routine.
No, it's the most unusual interruption I've had. Maybe it was what I was saying that induced it.
Well, it's Friday. There we go.
Yeah, and we're ahead of schedule anyway, aren't we? So there's time for a quick dance break.
Just ask everybody to mute, including that masked man that just came on then. Dan, I think we should start again.
Okay, thank you. So I'll take it from the top again. So as I said, I'm an epidemiologist at the University of Liverpool, and I'm leading the fieldwork side of COVID Live along with Professor Neil French. The COVID Live is a community household cohort study which will look to recruit about 300 households and cover nearly 1,000 people across the Liverpool city region. The principal aim of this study is to understand the epidemiology and transmission within household, which includes precise measurements of transmission and secondary attack rates in household, investigation of the virological, social and physical determinants of transmission, and for gaining a better understanding of the contribution of asymptomatic and mild infection. The households which will be included, if all individuals within that household consent to participate in regular nose swabs over an initial 12-week period and give blood samples at baseline and at 12 weeks. Participating household members will undergo weekly nose swab self-sampling and symptom recording, with intensified swabbing following a SARS-CoV-2 detection, plus immunological assessments to measure rates and determinants of disease transmission. We intend to characterise multiple parameters which may alter the risk of transmission, including viral load, physical household structure, and contact patterns within the household, and provide a description of the immune response to infection. The immunological study is an important component as it will give us an access to individuals who are asymptomatic or minimally symptomatic. This will help us to understand the requirements of a good immune response and by comparison with hospitalised cases, why in the minority of individuals things go badly wrong and severe illness ensues. There are additional complementary projects on health economics, behavioural and psychological aspects, including questioning people on their response to social isolation and coping mechanisms during this period. There is also a component which will be led by the vets to discover whether their companion animals play a role in COVID transmission. These projects are being integrated within this community study to provide unique data and give added value, creating the Liverpool COVID-19 Community Laboratory. We will create knowledge of immediate relevance to disease control and inform improved models of the pandemic, and consequently decision-making around social distancing and its further relaxation. Now, as we all know, just prior to ethics submission, the country exited lockdown and restrictions have been eased further. Therefore, the environment and stage of the pandemic which we will conduct this study under is constantly changing. This means that this study must be adaptable to change and will answer questions as we come out of the first peak of the pandemic in Liverpool, and will look to be innovative as we go forward. The epidemiology and virology study that I've been discussed has been through NHS research ethics, and we've just responded to comments from the panel. And as Elizabeth talked about earlier, identified through LHP and the CRM, we've established a small team of fantastic volunteers who've given up their time and skills to get COVID Live up and running. Now, whilst we're short on research nurse support, colleagues across the institutes are working hard to help identify additional research nurses to support the project. The study training for volunteers has begun, and with further training next week. We therefore anticipate with NHS recruitment, we will be able to begin recruitment and enrolment as of the 8th of June. An incredible effort from the laboratory teams at LSTM and the Institute of Infection, Veterinary and Ecological Sciences at the University of Liverpool has meant that staff and laboratories are prepared to accept and process up to 50 samples a day and will likely process over 10,000 samples over the 12 weeks. The COVID Live study and the additional studies are multi-institute collaborative responses to the pandemic, which will help build working relationships and capacity across these institutes, allowing all of us to better serve and improve the health of the people in the Liverpool City region. Thank you.
Thank you, Dan. There's some questions for you on the chat, Dan, so don't go away. And they relate to the way that you're going to select the households. Okay,
sure. So what we'll be doing is with our partners over in public health, there was a household health survey that was conducted in 2015 and 2018 across the Northwest region, which recruited around 7,000 households. And these households gave consent, or some of these households gave consent to be followed up for future research. So what we've done is identified a stratified random sample of these households within the Liverpool City region. And we will be contacting them via telephone in the first instance to try and recruit our sort of target of 300 households.
And David Perkins has a question for you about ensuring a suitable cross-section, because we know that socioeconomic status is a risk factor for transmission. So how will you?
Yeah, so we've focused in on Liverpool, Sefton and Knowsley, which have obviously quite substantial socioeconomic deprivation, particularly in comparison to where some of the other sort of cohort studies are being conducted, such as Oxford. So yeah, in terms of the stratified random sampling, we're sampling in relation to actually what we see across the region, which is obviously hugely deprived in parts.
Okay, so are there any other questions for Dan? This is an important study. It was actually the first study. Tells you how complex it is that we're just getting to the point where there's enrolment's about to begin, but underpinning many other biological, social, psychological questions related to transmission dynamics. And then sort of just one other question, Dan, about can people that have already had COVID, either proved or otherwise, be included for enrolment?
So the eligibility criteria would be that if someone in the household has been COVID positive, then they wouldn't be eligible to participate. But if they've previously had symptoms, then they would be. But as long as it's not COVID positive.
Okay, all right. Thanks for that, Dan.
No problem.
Now is Clarissa on?
Yeah, hi, I'm on.
Okay, Clarissa, off you go.
Okay, do I need to start my video, or do we just have the background here?
There are some slides showing. You have a...
I don't have any slides for the project, no.
Okay, off you go then.
Okay, so yeah, my name is Clarissa Giebel. I'm a dementia care researcher at the Applied Research Collaboration at the University of Liverpool, and I'm leading on the COVID-19 dementia study. So what we've done is it's a two-part study. The first part was a qualitative telephone interview study. So what we wanted to understand was the experiences of people that live with dementia and their family and unpaid carers on accessing social support services in the time of COVID. So because of the public health restrictions such as social distancing, lockdown, most of these social support services have had to close down. What we mean by services, that includes daycare centres, respite care for carers, peer support groups, singing and dancing groups in the community, all these different aspects, befrienders coming into the home or paid carers coming into the home. And there was no research out there before looking at how that can actually impact on the day-to-day life and on the symptoms of people living with dementia. So we've done 50 interviews over the phone in April with up to 10 people living with dementia and around 40 unpaid carers. And we've just submitted the first findings. We're just still analysing the data, but what came out overall was a very negative sense of experiences, which is kind of what we would have expected, but it has such a wide-ranging impact. Indirectly, COVID, it's not that people are affected and infected by COVID, but it has such wide ramifications in terms of how people with dementia and their carers are living their lives. They have to make adjustments. They have to reassess the risks of paid carers coming into the home because they might bring the virus with them into the home. And the second part of this study, which is part of it are still ongoing, it's a longitudinal online and telephone survey. So what we're trying to do is to understand the impacts of these service closures and accessing this type of social support on the longitudinal mental well-being. So what we're doing is we're asking people with dementia, unpaid carers, as well as older adults without cognitive impairment across the UK, what types of services they have accessed before and since COVID. And then we're asking them some standardized questions, for example, on depression, anxiety, quality of life. And we've just finished wave 1 data collection, so that's the baseline, in April and first week of May, and we've had 660 responses back, and we're just in the middle of collecting data for the second wave right now. And similar to the qualitative study, we're just writing up the findings now, but there have been some very negative impacts on well-being. And yeah, that's our study.
Thank you, Clarissa. Can you tell me where you work?
University of Liverpool in the Department of Primary Care and Mental Health.
And have you, and your collaborators, are they all from the same department?
No, oh, sorry, no. So it's a very broad collaboration with lots of third sector organisations and support organisations, for example, the Brain Charity in Liverpool or the Lewy Body Society nationally, Tide Carers. And for the survey element, we're also working together with UCLan, UCL, Bradford University, Lancaster University, so it's very broad. And on that note, actually, we are just now expanding on conducting the exact same study in Australia, Poland, India, and Italy as well. So ethics have started in all those countries. So we're going to have a large cross-country database comparing the data.
Can I ask how your work is funded at the moment?
It's funded by the COVID response from the Liverpool University Fund. And
there's going to be a large call coming from UKRI for mental health. Mm-hmm. Are you going to apply for that?
We already have put in some UKRI applications building onto that study, but yes, I'm sure we will, yes.
Okay.
And now you've committed to it in front of nearly 100 people, unfortunately. Thanks, Clarissa.
Thank you.
Okay, are there any other questions? Actually, we sort of have about 5 minutes if people would like to ask any of the speakers any questions or they have any other general comments. So while you're thinking then, let's keep moving forward. So the last agenda item is about restarting research. So the restart has already happened. So remember, I began by telling you about the UPH committee, which will remain standing to keep assessing potentially strategically or nationally important studies, but also to act as a performance monitor. And of course, there may be an issue about a second wave, as some of you have referred to, and if that happens, the UPH portfolio will again be prioritized and other studies will be stood down. But the restart has actually happened, so that the portfolio is now open as it was prior to COVID-19. But I guess what we would like to talk about is a word that Rachel has taught me this morning, and that's recovery as a more strategic approach to how we conduct clinical research in Liverpool together to optimize our productivity together. And so in terms of that process, the city is coming together, the R&D directors, the trusts, and the University and School of Tropical Medicine, the sponsors, in terms of trying to come to a more strategic view about what we should do first of all and how we can support studies starting to enroll again. And LHP will run with this process and take a strategic view so that we can maximize the way in which that's done. Actually, it's a very complex, as you can appreciate, process. So that process is happening as we speak. So I guess the most important thing here, and this comes up time and time again, and really I do not know how to fix it, is the communication problem. And so one thing that you could maybe help with in terms of chats and suggestions is how we can communicate better. We keep falling into gaps between organizations, I think, in terms of communication. And this webinar is an attempt to get across some of those issues, but we really need to do a better job about that. So suggestions that you may have would be really gratefully received. The second is your reflections, I think, about the process as you've heard it. It was done because there was a very urgent and serious threat to public health, but it's worked so well and it's got over so many issues about fragmentation in the city that we're interested to know whether some form of this process, it would have to be changed, of course, in terms of reference would have to be altered, whether this would be, you'd like to see something like this go forwards in the city to manage the city's clinical research portfolio for the betterment of health in the city, what you feel about that. And then finally, I think, is what you think the name of that process should be. So we have, because we were faced with an emergency, use very sort of maybe aggressive language, words like command and control, and people may not like those words, but it's not supposed to be dictatorial like that, but it is, we've used maybe words like, maybe more appropriate words would be alignment and strategic and coordination, but we'd be interested to know about what words you think. Okay, so they're some of the issues that we're interested in hearing back from you about. Now, Sandra Smith, how is the dissemination of research results happening? Well, first of all, Sandra, you actually have to have some results to disseminate. So the only results that we really have at the moment are the UPH statistics. I mean, those studies are not reporting yet. They will report, the first will report in 4 or 5 or 6 weeks. In terms of our own dissemination plan from our own portfolio of work, those studies are still up and are going. Does that answer the question, Sandra?
And William, I think there's a significant proportion of the health service research and the qualitative social science-led research projects that are producing results much more rapidly as we go and as we learn. And there's a lot of involvement within those programs in working with the local authorities and the combined authorities to try and provide evidence and needs assessments based on evidence to help shape their recovery plans as well. So maybe our next steps are about trying to get that system-wide balance so that we're supporting the whole system as it needs to be supported.
Okay. Thanks, Rachel. So, Julia, the differences in the way we came together compared to business as usual is the critical question, I guess. So COVID-19 prompted two things. One, people were dying from this disease, and so something had to be done very quickly, and there was clearly a common good, but there were also finite resources for clinical research. So that means that there were only so many patients could go into clinical studies, so you had to make a decision about which clinical studies to support. We had to cooperate across hospitals so we didn't get into competitive struggles. There was only so much money, there was only so much laboratory space. So the difference between what we're facing now was there was common purpose, I think, rather than investigator-led initiatives or interest at either an investigator or at the level of the trust. So the whole city was under threat, so it required some sort of common functioning and good. So that's really the difference now, is whether we can use something like this, a structure like this, to address problems in that affect the city as a whole. I think that's what we're trying to understand in terms of our responses to COVID, whether they can now be adapted and adopted for other processes. So, for example, this is happening right across the piece. So NIHR have been very impressed the way that different medical specialties have come together. I mentioned to you that UPH has infectious diseases, critical care, social science, respiratory physicians, and they've all come together for the common good and purpose. So they like that idea very much. Right. I'm not sure who iPhone is, other than all of us. Maybe you can, iPhone, you can type your name so we know who you are. Who can talk to the impact on community, because that is a
so William, there are a few programs going on. I was just scrolling through participants. I think I saw Sally Sheard's name earlier, who is leading a lot of the social sciences research.
There you go. That's perfect.
And helping to coordinate across the university. So Sally, I don't know whether you're still on the line and able to talk, but equally Carrie has been, from NHP, has been supporting a lot of that work and works within our Starting Well programme, leading those pieces of work. So that includes some of the child and adolescent mental health and recovery work.
Hi, Rachel and William. Yeah, we've got, this is Sally Sheard here. We've got 6 projects we're running at the moment through the Social Science Collaborative that have had pump priming from University of Liverpool. And we have now extended that centre, that collaborative network, to include representatives from John Moores University and Edge Hill. And we are building relationships with the Liverpool City Council so that we have direct routes to feed the outputs of the research into the recovery plans. And I co-chair the Health and Social Care Recovery Group with Matt Ashton, who's the Director of Public Health. It's a very exciting time, and it's great that we have got social and behavioural sciences fully embedded. There's a bit of work, I think, still to do, as William says, around comms on this, to make sure that the language is inclusive across all levels. We are getting there, and it's good to be involved. Thank you.
So Sally, do you see that this is a viable strategy moving forward for the way we conduct all sorts of clinical research in the city? Narrow biomedical science as much as more broader community-based social science?
I think it is, William. I think we need to make sure that we have a sort of a systematic approach, so that whenever new projects are started, we have a checklist to make sure that we have representation where possible from social and behavioural sciences on new projects. I think Liverpool Health Partners has a key role to play in this, and the emphasis really must be on the health in Liverpool, not on the biomedical responses to ill health.
Yeah. Yeah, and I see knowledge of community from the ground up. So yeah, I think that I mean, a number of us are very keen to try and bridge this gap in between our very narrow biomedical world, which I live in, to a broader community. And COVID-19's given us an excuse to really try and do that, and that's been interesting and a blueprint for the way that we work in the future. So Martina, okay. All right, well, so it's nice to see some interchanges on the chat function. So if we'll capture these and Elizabeth can feed back. So just one final thing before I let you go and prepare for the weekend, and that is, should we do this again, as it's been helpful? And if you can't tell us now, then would you let Elizabeth know? And I think she's going to send out some feedback sheets so you can tell us what you think, because we're very keen to make sure that the momentum, Sally said, that we've generated is captured, and we can use this constructively in the future. Okay, I think that with that, I might call. We're just about at the hour, and I might there's some contact details for you. I might draw the webinar to a close. Wish you a very pleasant weekend and look forward to talking to you again in the near future. We'll let you know about future initiatives in terms of webinars. Okay, thank you everybody. Thank you very much.
Thanks everyone.
Bye-bye.
Okay.
Thanks.